Okay, well, welcome. This is the New Perspectives on Women's Health and Spinal Cord Injury, Addressing Unique Challenges in Advancing Care webinar. I'm so glad that you can join us this evening. It's a really special opportunity for us to get together and talk about some important issues. And again, I want to thank everyone who helped organize this and all of you who are joining us this evening. Just as a point of note, I want you to be aware that we are going to be recording the session and we will make it available to a larger audience. So we are going to be doing that. And I also want to let you know that we're going to be open for questions at the end for a Q&A. So if you have questions, please post them using the chat feature, and then we will address your questions at the end. You'll also have an opportunity to unmute if you'd like and to ask your questions at the end of the webinar. So with that, let's get started. I want to acknowledge that this webinar is sponsored by NIDLR and is part of the Spaulding New England Regional Spinal Cord Injury Model System program. So this is one of the wonderful things that we're able to do as part of the Model Systems program. And again, I'm so pleased that we can do this to support the model systems and the good work that they do. We're very fortunate to have two incredible presenters today, Dr. Chloe Slocum, who's the Director of Health Policy at Spaulding Rehab, Assistant Professor and Associate Chair for Quality at the Department of PM&R at Harvard Medical School. And she's accompanied by Kimberlee Watts, who's a peer health coach and mentor, and who's been an advocate for people with spinal cord injury for over 22 years. She's also a mother and a grandmother. So we have a lot of expertise here. And just to go over the agenda quickly, a brief introduction, then we're going to stop and have Kim's story. Kim is going to talk to you about some of the issues that she's encountered as a person living with spinal cord injury. After Kim's story, we're going to have a time for questions and answers, sort of the common questions that women with spinal cord injury have. Then we're going to go into a presentation by Chloe Slocum on important topics. And then at 6:45, we're going to conclude the formal presentations with an opportunity to answer your questions. So let's go on to Kim's story.
Hi, I'm also very grateful to be part of this presentation. I want to thank Chloe Slocum and everyone else involved. I'd like to share part of my story with you. I was paralyzed in 1998, and after a short stay in ICU, I was released to a rehab that taught me how my spinal cord injury was going to affect me and how to talk people through the care I would need. They told me about the assistive tech options I could use and arranged for me to try them out. Once I was home, I had to learn how to pick up the pieces of my life, just like all of us do when we have a traumatic injury that impacts our ability to function. I had to learn how to manage caregivers, manage my health, and still be a full-time parent to two wonderful little girls. They gave me a reason to want to be here each and every day. It wasn't easy, but luckily I had family support, and I was able to put together a team of healthcare providers that truly cared and listened. A primary care provider who is part of a women's health clinic and has a genuine interest in her patients and takes time to make sure their needs are met. A physiatrist whose training and expertise in the field of spinal cord injury and its long-term management and uses this knowledge to thoughtfully develop my plan of care. And a dedicated registered nurse who expertly navigates through my complex health issues 365 days a year. Without this amazing group of people, I probably would not be alive today. I had several chronic conditions and complications related to my injury, and they threatened my life multiple times a day. I learned fairly quickly that many of the other people living with spinal cord injury were not as lucky. This motivated me to be part of several and work on a series of projects designed to help improve the health and well-being of people living with spinal cord injury. The knowledge and skills I gained from the rehab and working on those projects, along with the amazing team of providers I had assembled, helped me stay out of the emergency room and hospital. In 2018, my state's healthcare reform threatened to change all that. Because of it, I got to see firsthand some of what others go through. I was told I couldn't see my primary care provider anymore because of where I lived. I also learned there was only one primary I could see if I wanted to stay with my current health plan. This plan allowed me to see any and all specialists in the area without having to worry about whether or not they were in or out of network, as long as they took my insurance and I had a referral from my primary. I called my new primary's office and prayed she referred me to my current specialists, especially since if she didn't, I really wasn't sure what I'd do. I was relieved when I found out she would. However, I was told that any new referrals would only be made by providers in a specific healthcare network. It really wasn't the way my health plan was supposed to work, but frankly, at this point, I had no choice. I was nervous. I had managed to stay out of the ER and hospital for 20 years, and I was afraid that was all about to change. Since my health issues are complex, I put together a document describing many of them. I knew it would be hard for my primary to hit the ground running, given the many issues I have going on. Primary. She talked about making several changes to my medications, even though it was currently very stable with my medication. She also questioned why I didn't have an invasive surgical procedure to stop my almost constant and sometimes excessive menstrual flow, instead of the less invasive one that had successfully stopped bleeding. I was also currently experiencing swelling in my vaginal area. I've been tracking it as my previous provider requested, so we could discuss the results and hopefully diagnose and treat it on my next visit. My new primary was not interested in examining this medical problem, so I requested a referral to an OBGYN. I also let her know that my physiatrist had been handling most of my medications all along, and I wanted that to continue. She agreed and told me that the OBGYN referral I needed would be given to me at checkout. She would refer me to someone who could not only deal with my issue, but also who was comfortable dealing with paralyzed people and the issues that can arise due to their injury. After all, this issue was included in my health synopsis I wrote for her, and it was nothing that should have been a surprise. I got to the checkout desk and asked for the referral. They handed me a printout of the OBGYNs they were referring to that month. It was not a special list of OBGYNs comfortable with working with paralyzed people or possibly even knowledgeable in the area. It was simply luck of the draw. I was taken aback, but I decided to withhold judgment until I saw the doctor. I called the number given to me, made an appointment. They asked what it was for, and I told them. New doctors tend to want to adjust all your current treatments, and even the treatments that are working and have managed to help you stay out of the hospital and ER for 20 years. I went to my appointment the next day and met my new OBGYN. Her bedside manner did not exist, but I was willing to overlook that as long as I could get quality care. That's what's most important after all. I proceeded to describe my situation to her and the portion of my health history that was relevant to OBGYN. I explained how I'd gone into early menopause at the age of 32 due to my spinal cord injury, and how the doctors who were caring for me at the time restarted my cycle. She asked why. I explained it was in order to maintain my bone health. I would have thought a doctor whose specialty is an OBGYN would have known this. I mentioned that I had issues with my menstrual cycle being very. My primary had ordered blood work to see what stage of menopause I was in. She asked why my primary had done that. I was baffled. By the way, the test showed I had not entered menopause yet, but she glanced at the results so briefly I doubt she even noticed. My nurse, who provides RN level care for me 7 days a week, 365 days a year, took over from there. He told her how I had a vaginal ultrasound, and it was determined that I had microfibroids. She looked at my nurse and said, "We don't use that term. We use small fibroids." He explained that was the term given to us when we were given the diagnosis. She replied that she had different training than an internal medicine doctor. We were both dumbfounded since we knew that it was not an internal medicine doctor who diagnosed me and used this term. It was someone with the exact same training, an OBGYN. The primary diagnosed me since she had ordered the blood work. It was also painfully obvious that she had not even bothered to look at my chart, which is in the system. The topic of my vaginal swelling was next. I told her the swelling was mainly on the right inner labia, and it was significantly bigger than the left, and it started shortly after a Mirena had been inserted into my uterus, in an attempt to control the bleeding. I told her how, at the request of my new primary, I had been tracking the swelling for the last 5 months to see if there was a pattern. I had the results in calendar form. She looked at the current month and asked what the numbers next to the words right and left meant. I told her it represented the degree of swelling on each side, which was very different. After that, She handed the papers back to my nurse without looking at any. She diagnosed me with dependent edema. Prior to examining me physically, I was fully clothed. She said it was completely unrelated to the Mirena, and she did not want to entertain the thought that it might be anything else. She tried to make her point by asking me how long I was up in my wheelchair every day. I told her 6 to 7 hours, and she seemed to feel that proved her point, that because my vagina was below my heart level for 6 to 7 hours a day, which is less than most people, that it could only be dependent edema. And what she didn't know, and I didn't bother to tell her at that point, because I knew it wouldn't matter to her, was I'd been in bed for the previous 2 days, and that I had been in bed rather frequently lately, because I was trying to find a personal care attendant. I informed her that when the ultrasound was done, they were unable to. She seemed unfazed. She said she would go ahead and do a physical exam, but she didn't seem to think it was really necessary. A lot of places have accessibility issues. I've learned how to do exams in my chair while my nurse supports my legs so the doctor can insert the speculum to see what's necessary. My nurse raised my legs, and in an attempt to further support her diagnosis, the OBGYN said, "See, the swelling is going down as he's holding your legs." My PCAs have told me that the swelling looks less from behind, which is essentially the same angle she was looking at me from. But I was willing to work with this and asked her, if I elevated my bottom on a pillow when I'm in bed, would it help to reduce the swelling? She said no. There's nothing we could do for it. The only thing that could be done would be hang my legs from the ceiling, and that wasn't practical. This logic didn't really make sense to me. She had started before she said elevating this area above my heart would reduce the swelling, and now she was saying it wouldn't. She then said the only thing that would correct this was a vaginoplasty, and to do any procedure on a person in my condition would be malpractice. This is not what my new primary thought, which only proves they weren't selective about the referrals. She was unable to find the strings of my Mirena, but didn't seem concerned. She said she couldn't guarantee the Mirena was still in my uterus, but since the bleeding had stopped, it probably was. While I agree with that assessment, I was concerned because she didn't seem to care if it might be in the wrong place and possibly be causing the swelling. She offered to do an ultrasound just to check if the Mirena was still in there, but I already knew I never wanted to see her again. She was not able to handle my situation. It was more than obvious that she was not comfortable dealing with a paralyzed person. At this point, I felt staying with my new primary was going to be detrimental to my health. If anything major went wrong with me, I would be referred to the next physician on the list of referrals for that month. And that thought terrified me. Not to mention, I wasn't sure if something wasn't really serious going on right now. I was not confident with her diagnosis because of the way she behaved, and she was not willing to entertain any other ideas regarding my swollen labia. And I knew edema could be treated with medication, and there were probably alternatives that could be tried. It didn't just have to be surgery. I truly felt my life would be in jeopardy if I stayed with my new primary. She may have been a very good doctor, but if her referrals aren't good, it doesn't matter. At the same time this happened, I received a notice saying I could now join the health plan that my original primary belonged to. I was finally able to rebuild my care team. Once I got back with my primary, she referred me to an OBGYN that diagnosed what was going on. Bowel accidents were causing my labia to swell because at times a small break would develop in the skin where a natural fold was in my labia. He prescribed a cream that would help. Less than 2 weeks later, the swelling was gone. Having providers who are willing to have you as part of their health team is important. If they're willing to listen to what you have to offer, keep an open mind and actively look for solutions, they're worth their weight in gold. Put your questions, by the way, in the chat if you have them. Otherwise, you can ask them later on. This experience prompted me to write a letter to the state, letting them know about it and other things that happened to me during the healthcare reform. I actually received a response, and it caused changes to happen. Not long after the pandemic, my physiatrist decided to retire, but she gave me time to find another physiatrist to replace her. The one I chose was Chloe Slocum. She's been invaluable to me and has helped me continue to stay out of the hospital and emergency room. Not only has she used her expertise as a doctor to do this, but she's gone above and beyond to help me obtain the things I need to do this. I haven't mastered everything there is to know about my body and spinal cord injury. You can never master it completely. Your body changes over time. But I've been given skills, knowledge, and resources to know how to navigate those changes. I've mastered the process of caring for myself. Knowing where to look for the answers when you need them, who to look to, and how to be a self-advocate can truly help you take good care of yourself. I'm currently working as a certified peer health coach with the SCI project and coaching for the community, SCI community. They are a culmination of the series of projects I've been part of over the years. This program can help you develop these skills. It's really great. I've had people talk about being able to accomplish and learn a lot because of it and really start to gain control of their lives. Part of our pill coaching training is motivational interviewing and brief action planning. These skills and our lived experience really God, what they feel is important. Health isn't just about the physical. It can be emotional, mental, social, and more. We let people choose what they want to do or not do. It's really all up to them. They get to make the decisions. They're in control. We can help them recognize and identify issues, areas that need work, or goals in their lives. We assist them developing skills, strategies, and solutions that will able to work effectively on those areas they wish to target. We tailor each session to meet their needs. It's all about them. And we can help them build skills like self-management, self-advocacy, and determining reliability of information. They can learn how SCI affects their body, what they can do to stay healthy, how to build and work with a healthcare team, caregivers, and more. We can help them by letting them bounce ideas, brainstorming an issue they're having. If there's an interaction they find that's challenging, we can role play it with them. We have a resource library that they can look at that's been thoroughly vetted and reliable. We can provide them resources for their specific situation and help them learn how to find reliable resources on their own. Each session they can choose from a variety of topics to focus on, like assistive devices, stress, anxiety, physical activity, adaptive yoga, leisure and recreation, relationships, fertility, parenting, pain management, and more. If they want to focus on a topic that isn't listed, we can do that too. It's a very flexible program. We accept people as they are and where they are. We accommodate their needs and wishes, and we strive to treat them with the care and respect they deserve. The INU is currently running a study for the newly injured, and coaching for the SCI community is being hosted by the Spinal Cord Injury Association of Connecticut. We're offering peer health coaching services to the SCI community free of charge. When you're a peer health specialist, you hear questions and concerns regarding women's health issues. Chloe Slocum is here to offer some insights into these questions and concerns. And if you could grab slides for us, please, Mary.
So now we're going to have an opportunity to go over some common questions and concerns for women with spinal cord injury, and Kim and Chloe will have a dialogue about some of these concerns, and we'll start with this. The concerns are on this slide.
One of the concerns is about exams, and whether or not people will be able to access quality healthcare because of an accessibility issue, and be able to get pap smears, mammograms, dental exams, simply because they can't access the equipment or they aren't able to transfer in the room because it's too small or they just don't have the lifts. And I don't know if you have any thoughts about that.
I think this is a great question. I think if someone's going someplace new, it's always worthwhile to ask. It could be that the same physician who you've established rapport with or been referred to has an office where they have more, for instance, they have more nursing support for individuals who may have autonomic dysreflexia, or they have lifts. They are required to provide them in some capacity, but they're not always as coordinated as we would like. And so it's definitely, and as Kim mentioned, really accessibility is like but one part of this. So it's always worth asking. I think it's worth asking as well too, in terms of we more and more have chaperones. But I think it's worth asking too, could a nurse or could an assistant be in the room with me? If you think that you may need help in terms of if someone, for instance, you know, would benefit from a spotter or assistance, or sort of just explaining what it is that you usually do that usually works. Or if it's a completely new environment, simply explaining, how you usually do things at home if you get into a specific position, so that they'll be able to try to replicate that as much as possible, and do it so that you're comfortable and you're safe.
It sounds good. And you mentioned the dysreflexia as well, so and that, so that's good. I guess next slide. Thank you. And they're also concerned about specific health issues, bladder infections and bladder management, bone density and menopause. I don't know if you want to tackle those one at a time. I probably would guess.
Yeah.
Yeah.
Oh, those are good questions. I think that the bladder infections and bladder management, I think these are really worth talking about, and it can be sort of a series of things in terms of if this happens, then we're going to plan to do this. Just like, if you're taking a trip or something like that, there's different points along that, and you can talk with each other, and it's a partnership. But I think bladder infections and bladder management, we work closely with our urology colleagues. Similar to primary care, there are urologists that may focus or have a specific focus or specific comfort. Urogynecologists are also very helpful sometimes, and can perform many of the same procedures. Ways to empty the bladder, we will usually talk with our urology colleagues as well. Infections, sometimes it's useful to have a team of infectious disease specialists, and perhaps a urologist or urogynecologist in addition to primary care. But I would, not be afraid to be explicit in terms of, if I have a urinary tract infection, or I think I have one, where should the UA go? Who should I be asking for a sample? And, when will I hear back from you? Because something that I get asked is like, well, who is a primary care physician that specializes in SCI? And I have to tell people, usually there's not one, but I think people that are open to learning, and then if they have a responsive team, that is really worth its weight in gold, because if you have someone who has really outstanding rapport, but it's very difficult to get in contact with them and it's impossible to reach the office, then that can pose a major barrier, even if they're the nicest person on earth. Bone density, I think, is important to think about, because bone density certainly is typically lower, especially in folks with more complete injuries. And we have various ways of thinking about treating that. But in general, weight-bearing activity can be really helpful in the absence of a fragility fracture. And we also do counseling around diet for that, and we work closely with our endocrinology colleagues. And it can be helpful to see an endocrinologist and talk through different options. There are many more options now than there were 10, 20 years ago. And so it can be helpful to check in, and to establish care. And if you've established care, a long time ago, to follow up, because there are things coming out every year. Related to that, menopause, we don't have great information on menopause. We have a wonderful colleague at Michigan who's published what I think is like the only, or maybe one of two papers on menopause in women with SCI. And what we know is that in that very small sample, they tended to have actually fewer autonomic symptoms like hot flashes, and more urinary symptoms. And there was no difference in terms of things like mood symptoms that were associated with menopause. So those could all be things that women with menopause could experience, but everybody's body is different. And I always say, like, you're an expert in your own body. So if something is going on, it's important to put it into words and explain it and sort of talk about it with your clinical team, and try to figure out what's going on. Because if something is bothering you or it's interfering with your day, or you're concerned about it, then it's worth, bringing up, so that we can talk about it and figure out what could be causing it, and then how we could treat it. Yeah.
And then pregnancy and childbirth is also some concerns as well. They're wondering how the spinal cord injury will affect the pregnancy, childbirth, breastfeeding, and what happens if they get autonomic dysreflexia during childbirth.
Yeah. Those are also great questions. Our obstetrician colleagues actually are on high alert for autonomic dysreflexia. It's like the #1 emergency. They have an obstetric practice guideline about it. So they're should be on high alert for that at least. But SCI can affect pregnancy in different ways. Typically, due to neurogenic bowel, people will experience more constipation and may need to change their bladder management methods, as women become more and more gravid later in pregnancy, simply just because there's sort of mechanical displacement of a lot of other organs by the gravid uterus. There are changes in blood volume, in terms of planning around labor and delivery. If someone has autonomic dysreflexia, we'll be planning very carefully, because they should be getting epidural anesthesia. Women with spinal cord injury don't need to have a cesarean section due to a spinal cord injury alone, but that can be indicated due to other fetal or maternal factors. I will say that if I, for instance, have a patient who comes to me and has questions about pregnancy and they're not pregnant, we will refer them for a preconception counseling with a maternal fetal medicine specialist to talk through any questions or concerns they have. That can be helpful to review any medications that you think, maybe like, can I take this while I'm pregnant? Can I not take this while I'm pregnant? And ask some of those questions, and then ask too about, who should I be who should I be connected with? Sometimes we'll say, well, we really should connect you with infectious disease, or we should meet early with anesthesiology, or, if someone has some baseline sort of restrictive respiratory deficits, or trouble taking a big deep breath, maybe meeting with pulmonology early on would be helpful. And we do a lot of anticipatory planning. For breastfeeding, our colleague Andrei Krasiakov, who's in Vancouver, has done a lot of work, and our colleagues in British Columbia as well have just done fantastic work on that. Women with higher level spinal cord injuries can, because of the way that it affects the autonomic nervous system, can have decreased milk letdown, and they've trialed, I think, nasal oxytocin for that has had some good effect. But in general, there are lots of sort of collaborative partnerships, and I have some later in terms of it's not just about your physicians either. It's also about physical therapy and occupational therapy, and thinking about, what kind of equipment will you need at home? What will you, like, what will you do in terms of sort of some of these like key ADL parenting tasks, and thinking about those, and making sure that we're planning in a proactive way, rather than a reactive way as much as possible. Because as soon as you become a parent, you're going to be reacting. But yeah.
We have one more slide.
Okay.
Can we do that?
So
I had to get rid of my Amazon device.
oh, that's okay.
We also have problems in terms of relationships with medical teams. And a lot of times women with SCI are tired of always having to self-advocate, because they have to do it a lot, unfortunately. And we were interested in having doctors that welcome our input and want us to be part of the team, and respect our opinions. And then there are issues with staff, which is on the next slide, I believe. But if you want to talk about a little bit about just the more positive, side of this right now, I think that.
Yeah, I think so. I think relationships with medical teams, and I think part of the difficulty too is that, as you mentioned, there's staff, you're sort of interacting with so many people um, in a short period of time, and explaining a lot of information that may or may not honestly already be present in the medical record or the summary if you sent it to them that they should have reviewed. And so I think that the finding a provider who is curious and who's willing to learn, even if they don't have an intricate and deep knowledge to begin with, is really valuable. I think that someone who welcomes your input is helpful, and takes the time just to listen. Um, Sometimes if I'm confused, I'll sort of ask more questions like what does that mean to you? I can think of times where someone has told me something that doesn't necessarily make sense according to the textbook knowledge that I have from medical school. But again, like when a baby is born and it's not according to the textbook, it's not as if like we put a textbook under the bassinet for the baby and it just absorbed it by osmosis. People are sort of trying to describe something about their bodies. And we don't always use the same language to do that. And so it can just be helpful to be curious and ask questions, and finding someone that will do that is important. I think in physical medicine rehabilitation, we sort of train as a field to focus on issues like spinal cord injury and other conditions that may cause forms of paralysis. And so we like to think at least that we're sort of predisposed to do that. But everybody is different. And so I think having someone that is willing to learn more, not just from you, but also willing to educate themselves so that you're not having to educate them all the time, is important.
How would you um, issues with the medical staff and the way they're being treated? A lot of providers lack disability knowledge and education. They can be very dismissive, patronizing, and sometimes they'll actually talk to whoever's ever with you rather than actually talking directly to the person that they're treating. And I personally have actually had trouble with when I was having some breast imaging done, them trying to pressure me into do something my body could no longer handle. Instead of doing the imaging that my primary had ordered, then there's just times that doctors don't necessarily want to look further, as you heard with one of my interactions. They would just want to blame it on the spinal cord injury, and they don't really want to look at issues that really could be going on that are not really related to spinal cord injury. I don't know if you have any insights on how to deal with all of that.
Yeah. These are great sort of, and unfortunately, these are great questions, but unfortunately, common challenges that we hear about.
Unfortunately, yes.
I think in terms of dealing with attitudes, I think that we talk about this from a physician standpoint, at least when we think about follow-up, because when people don't follow up when we ask them to, um, when I talk to other physicians, I would say, actually getting down to brass tacks and understanding what happened, and what went on and like why that was. And again, coming at it from a place of active listening and curiosity, I think can be helpful because it could be that somebody had a scheduling conflict. It could be that, the paratransit didn't show up. It could be that they've had so many negative experiences that they just didn't feel like going back. And we treat all of those in different ways. And so we really do have to, diagnose the problem in a rather technical way using empathic listening to figure out what would best treat that. And for providers, I think that from a physician standpoint, and when physicians sort of, sort of talk, get frustrated with me sometimes, they're like, well, why do I have to learn about this or something like that? I would say, like, well, it's natural to be frustrated because nobody taught you this in a terribly structured manner in medical school. But it's like, it's, imperative for all of us to try to get better at the care that we're providing to the person in front of us. And that's why it's important to always keep learning. In terms of staff, I think we have a long way to go with staff, but also realizing that if it really seems like there's a systems issue, like sort of everybody is totally unaware, then that's very reasonable to speak to the clinic manager, or to, as Kim did, if it's an issue with your insurance plan, to sort of formally say, this is really a problem, and this is what, like, some things you could consider to fix it, because certainly. A dismissive attitude, or somebody being patronizing on the phone, or somebody simply not knowing what the appropriate equipment would be, or refusing to help, it's low-hanging fruit. Doesn't require a huge investment to fix that. Talking to a companion might be helpful for, yeah, it should be the primary historian. Talking to a companion, it might be helpful to speak with a companion so that the companion can play an active role in, like, redirecting that, or you know saying, this is the focus is actually the person here in front of you, seeking medical care, and they have the most up-to-date information, and they can tell you about their body, and care options. I think, again, sort of talking about, like, why this is the best thing for me. These are all the things that I have considered, and this is my reasoned opinion of why this is more valuable, and frankly, safer and more comfortable than what you're recommending. And so I think that that's, it's always okay to say that. I think oftentimes we're sort of embarrassed, or we feel like, oh, maybe people will have a negative reaction to that. But that's a very reasonable thing to to state, just as a need. And if people are not listening, saying, like, this is important to me, and it's important to me to maintain this relationship. It really is a relationship, and of course, relationships are two-way streets. Even if we can feel in a medical setting like there's a hierarchy, and I'm supposed to be taking instructions, but really the person without the knowledge in this situation is sometimes the physician, unfortunately. And so if something is important, I think holding your ground on that can be helpful.
Okay,
That
I'd
sounds
like to
good.
transition now. I think we've gone over the last two slides around the goals of what the world we would like to see. And now Dr. Slocum is going to do a presentation, and then we're going to conclude with the time for questions and answers. And I see people are putting things in the chat, so keep doing that, and then we will get to those right after Dr. Slocum's talk. So I'm going to stop sharing.
And I'm going to start sharing. Just a moment. And Mary will keep me honest on time. Okay. Whoop. And I'm going to switch the view. How's that?
Good. Presenter mode.
We're in presenter mode?
Yep, got it. Perfect.
Okay. Okay. So I'm going to just talk briefly about this. In spinal cord injury medicine, we tend to be very detail oriented as physicians, keep track of a lot of information, and we're always thinking about algorithms and prognosis and sort of medical systems. I was going to say, though, that medical facts really only tell a part of any person's story when I'm in a clinical visit with an individual, and thinking about really their context, their unique needs, desires, wants, goals, preferences. All of that's really important for delivering high quality care. I like to think about the biopsychosocial model and the World Health Organization International Classification of Functioning. And as we can see here, the health condition and the body function, structure, and activities, really the body function, structure, and health condition are the things that we have the most information on, because we publish a lot on them as physicians, and these are the things that we have sort of evolved as a medical field to focus on. And in physical medicine and rehabilitation, we talk a lot about activities and participation, and we focus on these to some extent as a discipline. But there's also environmental factors and personal factors that are important to discuss and learn more about and incorporate into plans so that we can help folks succeed when we're seeing them in clinic. Oops. So we have many guidelines for spinal cord injury. Some of these are guidelines about just outcomes, pressure injuries we think about, including in women who are pregnant, respiratory management, blood clots, upper limb function, which is very important for individuals who are using a manual wheelchair, propelling as their primary means of mobility, bone health, autonomic dysreflexia, and bladder management. These are all important areas. And I'm very proud that the Consortium for Spinal Cord Injury Medicine has been at this for a long time. And our surgical colleagues have actually published recently in, I believe, 2022 or 2023, they published their first spinal cord injury guideline. However, even though we know this in certain areas, we know a lot less in other areas, and not surprisingly, women's health is one of those areas. So in 2024, I published this paper with colleagues from our PM&R department, as well as our obstetrics colleagues, and we looked at across all medical databases, and we found about 21 articles that were related to contraception in women with spinal cord injury. We excluded 144 articles that were related to, for instance, things like fertility in animal models, things that were not particularly relevant clinically. The majority of these were actually literature reviews or professional practice guidelines. There were a small number of case studies, and then a larger but still minority that were primarily focused on research, including the menopause paper that I mentioned earlier. The types of contraceptive methods that were discussed were interesting to us. These mirrored some of the things that we saw in other professional practice guidelines, but interestingly, even in relatively recent papers, emergency contraception, which is very important to our clinical population in terms of women of childbearing age, and also for individuals who we might be treating or have questions about that come up during appointments. These were virtually nowhere. In fact, the one guideline that emergency contraception was mentioned in was a pediatric practice guideline, and otherwise it was absent. So we also learned that our obstetric colleagues were existing in another silo where they had these national guidelines that included, for instance, women with multiple sclerosis, but did not include spinal cord injury, and that there were a lot of consumer-based or consumer-focused educational materials that didn't specifically include women with spinal cord injury or other mobility impairments, apart from the one mentioned of multiple sclerosis in what's called the MEC, or the medical eligibility criteria. We actually created in our paper a table of options that are similar to what is provided in some of the national sort of clearinghouse guidelines. In addition to what they talk about in terms of different levels of efficacy, we highlighted concerns for bone health and blood clots with some of the hormonal methods, some issues around, for instance, intrauterine device implantation for individuals with autonomic dysreflexia or impaired sensation, issues with reliability of barrier methods in terms of folks who have impaired hand function, fertility awareness being less reliable due to issues with thermoregulation, again, in individuals above T8, and then the virtual lack of emergency contraception guidance around this. Again, we have a lot of guidelines. As you'll notice, there's not a guideline focus featured here because we don't have one on women with spinal cord injury. But we do know certain things medically, and that's amenorrhea can occur. It doesn't represent menopause in the post-traumatic sense. And the information that we give women with spinal cord injury in the rehabilitation setting, while being desired in many cases, is inadequate even when we do provide it, and we don't provide it as often as we should. Bias is really prevalent in healthcare settings. There can be scheduling avoidance by providers, failure to provide appropriate equipment, implicit bias broadly, and as I said, and disparities in cancer screening as well, both for breast and for cervical cancer, which we think relates both to attitudinal bias and potentially seeing women with disabilities as not being sexually active, or also a lot of accessibility barriers in terms of just things like lifts and staff training on how to use lifts that could be contributing. As I said, I remind my colleagues sometimes it's important to think about why someone has avoided routine or needed care, and the potential for past experiences of discrimination to influence this, and to cause someone maybe to be more hesitant to follow up after a recommendation. Again, SCI is complex. We have a lot of guidelines, but listening doesn't have to be. So I think part of this begins with listening and being able to have a conversation and being able to not jump to diagnosing something without hearing someone's full story. Recommendations for clinicians that I will give. So facility accessibility is often beyond the purview of an individual, but incorporating screening into clinical workflows can help embed awareness. Training staff is especially important because although you may have equipment, not having staff to operate the equipment limits its use. There are historically some tax incentives and that may be helpful with capital budgeting. Scheduling may be influenced by transportation and personal care issues, and it's important for clinics to realize this because clinics may block slots for new evaluations, for instance, at like 8 in the morning or at specific times of day. This may be just not feasible due to scheduling and due to personal care constraints. Though it's important to recognize that. And then screening can also be complicated by cultural and generational differences in describing disability. I'm just going to blast through these, but these are some collaborations. These are the ACOG guidelines I talked about. And in all of these cases, I think it's important to remember these have been informed by women with SCI and their experiences. We have infographics and infocomics with the MSKTC, or the Model Systems Knowledge Translation Center, that have been developed by NIDLR. Our colleagues in TIER have CROWD, or the Center for Research on Women with Disabilities. In Pittsburgh, there is a Center on Women with Disabilities in collaboration with the Women's Hospital there. Our colleagues in Sweden with Spinal have a whole website that is actually also available in English that focuses on pregnancy and childbirth issues for parents with spinal cord injury as well as women with spinal cord injury. In Queensland and Australia, they have a whole occupational therapist that worked on this, but all sorts of adaptive equipment for parents with spinal cord injuries. And again, our colleagues in British Columbia have both consumer-focused materials on women's sexual health and pregnancy, as well as guidelines and protocols for clinicians working in the hospital. And we have a course that's aimed at clinicians as well, that is free, that I'm happy to say over 15 countries, and clinicians from over 15 countries have participated in. All right, I'm going to stop share and then we can take any questions that folks have. I'm going to look at the chat.
A question In my area, there are no longer any physiatrists who follow patients long-term or even as outpatients at all. This includes those who are board certified in SCI medicine. What do you suggest be the source of physiatry input into care?
Repeat that, Mary.
In my area, there are no longer any physiatrists who follow patients long-term or even as outpatients at all. This includes those who are board certified in SCI medicine. What do you suggest be the source of physiatry input into your care? How can, yeah.
This is a good question. This is
Input.
a very good question. Um, my first and second steps would be sort of to seek more information. So in the community, if there is knowledge about a specialist, sometimes it can be helpful to reach out to insurance because they may have a list of providers. And I would say also there's a lot of virtual care. So there's virtual care that is available. Our colleagues, it's not necessarily a substitute for a physiatrist per se, but our colleagues at Craig Hospital have a nursing line that actually has nurses that are licensed in every single state that can answer questions about SCI that I recently learned about. But in terms of an SCI medicine boarded provider, they may be difficult to find simply because I'm not sure that the board publishes a directory of them. Our colleagues at the Spina Bifida Association have tried to develop a public directory, but there have been barriers to doing it. And I know that our colleagues at TIER in Houston have also been developing a website that is public facing with sort of shared and crowdsourced resources for women with spinal cord injury. And those are good places to look, but I think also there are really wonderful physiatrists who aren't necessarily spinal cord injury boarded, who have great expertise. And then there are also folks like Kim's primary care physician who are responsive and willing to learn and simply go. I don't even want to say above and beyond because I feel like it should be normal. But
It should, but it's not, unfortunately.
yeah, just demonstrate real dedication to the best clinical care. And I think seeking that out is important, even if there's no SCI boarded physiatrist within a stone's throw.
I have another question. My doctor told me I cannot have a bone density test until I'm 65 or unless I hurt myself. What can I do? And a member of the audience actually replied to that. So a member of the audience said denial can be appealed and you have the right to request the specialty, i.e. a board certified person review the appeal. Any other suggestions?
I agree with Kathleen. I totally agree with Kathleen. Um, I would say the other thing too, is that there are, for instance, there are guidelines. Our colleagues in, again, British Columbia have sort of clinical practice guidelines, and if you can showing a physician sometimes in their medical format, like they sort of recognize that it's an article and that it's, they can sort of look at the research, can be helpful. But I think really the sort of stating that it's important and the that you'd like to appeal it should also be perfectly valid. You shouldn't necessarily have to track down research articles for your doctor.
Yeah, I've had one I'm not even at 65 yet, and I've had several already. So it is possible to do.
Yeah,
Just need
and
to
if
understand
it's
the
an
reasoning
insurance,
why.
if it's an insurance denial, that certainly could be appealed and would win the appeal.
Yeah, another question, or actually more of a statement. Many people are not familiar with ADA regulations related to access and medical care, both in offices and hospitals. So the responsibility should be the healthcare team. Any suggestions on how we can be more able to put the onus back on the healthcare team instead of the individual.
Yes. I think this is something too where this is a also I'll say I agree with Kathleen. The consortium guidelines are outdated. That was something again we they were published after emergency contraception had been in place, but they didn't mention it. So hopefully when they update it, they will. In terms of accessibility and ADA compliance, this can be helpful to address in the way that, for instance, Kim did in terms of access to appropriate physicians, but in terms of physical access, it can be helpful to speak with a patient advocate or a clinic manager, someone who may not be like the medical assistant that you're working with one-on-one, or the physician who sort of, is seeing patients again and again and again throughout the day, because they may not get to it in as timely a way as you want them to. And I would say also, while you can put it in your your patient satisfaction comments, that's often not a terribly effective way to flag something in a way that'll get a really timely response. And so I think bringing it up, you know, as soon after as possible with someone who has an operations role for the clinic, or patient advocacy, can be helpful and will usually get a response, and can help troubleshoot it. Again, it may be that the person may not have all the equipment in every site where they practice, but you shouldn't have to chase them around on a wild goose chase to figure out where the appropriate equipment exists. Like, they should be able to help coordinate that for you.
One of the things my primary also does is when she's filling out a referral, she'll put my conditions in there and the accommodations I need, which is one of the things that she does that is really above and beyond, but most providers should really do that for you as well, because that way I don't even have to approach it. She's been being the advocate for me, so I don't have to self-advocate in that situation. She might approach that with your primary as well.
Yeah, ask them to put it into your referrals. I like that. Thank you, Wendy, for putting the
So there are some very helpful links that have been put into the chat, the ADA guidelines, another resource on Through the Looking Glass for issues around parenting, custody, and divorce. So I don't think we have time to enter into those discussions, but the resources are there in the chat. Any last comments? We're 2 minutes from wrapping things up. Maybe if each of our presenters could just give a closing statement.
Sure.
Your choice.
I think that there's many things that are frustrating, and I think that a good thing is that every time I speak to medical students or residents, I'm heartened, because more and more our younger folks who are training and who are the next generation of physicians really get this in a way that I certainly don't think was as present when I was in medical school. And that gives me a lot of cause for optimism, because they will look at something, and I'll say, this is what we studied when I was, getting my boards, and it's not very different now. And they'll say, if I'm talking to my obstetrics colleagues, they'll be like, well, that's wrong, or like, well, that's outdated. Of course, of course we would use, an IUD, and we wouldn't think that just because someone had SCI, they were at risk for pelvic inflammatory disease. Like, of course, or like, of course, I want to know how to provide more accessible care from my primary care colleagues, if I'm talking to residents. And so I think that's a really bright shining light for me.
Yeah, I would suggest people to make sure that they find providers that are willing to listen. If you're with one that isn't, consider changing. Because if you have someone who's willing to listen to you, you do have to do some self-advocacy work. It's just inevitable. And educate yourself on your spinal cord injury and conditions, so that when you're talking with them, you can let them know more about your situation. But even if they aren't completely familiar with spinal cord injury, as long as they're willing to work with you and to treat you properly, that's someone you might really want to consider taking with you long term on your medical journey.
Yeah, I agree with Kim. It's like, don't stay stuck, like if just because.
Okay, well,
You're worth it.
That concludes our webinar, and thank you for the great comments and questions from the participants and from our speakers. Thank you so much for sharing your knowledge and experiences with us. And just so that you know, this will be recorded, and we will send everyone a link to the recording, and also we'll include the links that have been shared in the chat. So I think they're, again, another way of getting those resources. So when you finish this webinar, look for the recorded version, and we'll have the links accompany that. So again, thank you, everyone.
Thank you all.
Thank you.
A pleasure. Thank you, guys.